Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. This is part 2 of oral contraceptives. Grab a piece of paper and let's go. So back when I started this contraceptive week on my channel, I thought contraception is one of the topics that many people don't really understand. Even the most highly educated people actually have very little information on contraceptives. That's why I actually decided to do these videos. So if you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. In part 1 of these series of lectures, we talked about contraceptive basics. So if you didn't watch that video, I'll leave a card tagged at the end of this video such that you can go check it out. In this particular video, this is part 2, and we're going to look at oral contraceptives, both combined oral contraceptives as well as the progesterone-only oral contraceptives. Remember that contraception, as we already established from our previous lecture, is that intentional prevention of conception through various devices, sexual practices, chemicals, drugs, or surgical procedures. And remember how we talked about the different classes of contraceptions? Just to remind you, we have the hormonal-based, we have the non-hormonal-based, which include barrier methods, intrauterine devices, fertility awareness methods, lactational amenorrhea, and you also have some surgical methods. We talked about these in our previous lecture. So again, if you didn't watch that video, please pause this video and go and head over and watch part 1, because this will all sound quite strange to you if you don't have the basics, as these lectures are building upon one another. So today we're going to look at predominantly oral contraceptive pills, and they're going to be largely divided into 2 main groups. We have those that are going to be containing estrogen and progesterone, which are the ones that are going to be called the combined oral contraceptive pills, and we have those that are going to be only consisting of progesterone. So these are going to be these steroid hormones that are going to be inhibiting the release of gonadotrophin releasing hormone by the hypothalamus. Let me just give you guys a background before going into details of this. Remember that the endocrine system is under mainly the control of the hypothalamus as well as the pituitary gland, what we call the hypothalamo-pituitary axis. So there are certain hormones that are produced by the hypothalamus that have an influence on the anterior pituitary gland. So one such important hormone is the gonadotrophin releasing hormone. Once this gonadotropin releasing hormone is produced by the hypothalamus, it will stimulate the anterior pituitary gland to produce follicle stimulating hormone and luteinizing hormone. The follicle stimulating hormone stimulates the ovaries to develop the follicle, eventually starts producing hormones that actually send a negative feedback mechanism back to the pituitary gland and the hypothalamus to reduce the production of the FSH so that other follicles don't continue developing. And then roughly just at about day 13 and day 14 of the cycle, there's a surge of luteinizing hormone, which causes ovulation. And as long as there's an ovum there and the person has sexual intercourse, there's going to be fertilization and the person is going to fall pregnant. So these oral contraceptives are going to be these steroids that are going to be inhibiting the release of gonadotrophin releasing hormone by the hypothalamus, and therefore is going to be inhibiting the release of the pituitary hormones FSH and LH that are going to be stimulating ovulation. If there is no ovum, then there is no fertilization that's going to take place, because the egg is not there for the sperm to fertilize. Remember that the oral contraceptive pills can also affect the lining of the uterus. They can also decrease the likelihood of implantation if ovulation has already happened. They make this hostile environment in the endometrial cavity. They can also cause changes in the cervical mucus. They can cause it to thicken and then becomes impervious or impermeable to the spermatozoa, and they can also to some extent decrease the motility of the fallopian tube. If these are actually used consistently and correctively, they are actually an effective form of contraception. Now, remember that these can be started at any point from the age of menarche, which is the time a woman actually starts having these menstrual periods, up until menopause, when the menstrual periods actually stop. Remember also that the oral contraceptive pills, like I said, can be a combination of estrogen and progesterone, or they can be progesterone only. So we'll begin our discussion by talking first about combined oral contraceptives, then we'll talk about progestin-only contraceptives, then we'll come and look at certain contraindications, we'll look at certain side effects of these oral contraceptives before we end our lecture. So remember that these ones which contain estrogen and progesterone are by far the most effective reversible method of contraception, and they're going to be consisting of two main types of hormones. They're going to be consisting of a synthetic estrogen, which is usually ethinyl estradiol, or they can actually consist of the estradiol valeriate. So it can either be ethinyl estradiol or estradiol valeriate. Then they're also going to be consisting of a progestogen, a synthetic derivative of a progesterone. This could either be first generation, which are not so common in the market. You could have second generation, third generation, and now even have fourth generation progestogens. So since these contraceptive pills were actually first introduced, the doses of estrogen and progesterone were initially very high. But as we went on and on, we tend to reduce the doses of these drugs, and this has actually improved the safety profile of these drugs. And at least about 200 million women worldwide have taken the contraceptive pills, the combined oral contraceptive pills, since they were first marketed. We also have some combined hormonal patches and combined contraceptive vaginal rings that we will talk about in another lecture, but just know that because they have these hormones just like in the combined oral contraceptive pills, the side effects will be similar, the adverse effects, the benefits will be similar to the combined oral contraceptive, and even how they work will be quite similar to the combined oral contraceptives because they have the same hormones in them. And then also remember that the combined oral contraceptive pills are very easy to use, and they offer a very high degree of protection against pregnancy and have many beneficial effects that we'll talk about. For example, women have decreased risk of developing ovarian cancer, decreased risk of developing endometrial cancer, decreased risk of developing the colorectal cancer. These are not side effects of the drug. They're just beneficial effects that we see of the combined oral contraceptive pills. And these are going to be used mainly in young, healthy women who have no other contraindication to taking these oral contraceptive pills, and they want to take a contraception that is going to be independent of intercourse. Because remember that there's some things that are dependent on intercourse. For example, spermicides need to be applied every time before someone has sexual intercourse. And for this maximum effectiveness of these combined oral contraceptive pills, they should be taken regularly and roughly at the same time of the day. It's better to take them at night before going to bed. So the mechanism of action of how they work is going to be in two parts. It's going to be a centrally acting mechanism, predominantly affecting the gonadotrophins, affecting the FSH, affecting the LH, or it could be peripheral, affecting the cervical mucus, affecting the endometrial cavity. They may actually cause the endometrium to become atrophic. So in terms of the central mechanism of action, remember that it's going to be inhibiting ovulation. This is the most important effect that I want you to keep in mind. Both estrogen and progesterone are going to be suppressing the release of the pituitary follicle-stimulating hormone as well as luteinizing hormone. Remember, follicle-stimulating hormone helps in development of the Graafian follicle. The luteinizing hormone helps in the ovulation. There's a surge just before ovulation. So if you prevent these hormones from being produced, there's going to be a prevention in the follicular development within the ovaries, and there's therefore going to be a prevention in ovulation. And if you don't have an ovum inside the fallopian tube, there's nothing that the sperm is going to find. Estrogen is going to be inhibiting the production of both gonadotropin-releasing hormone as well as FSH. So once we give these oral contraceptive pills, you constantly have a high level of estrogen, and it's kind of like the pituitary gland thinks that you have a Graafian follicle that has developed, and there's going to be this negative feedback, and this is going to suppress the development of follicle-stimulating hormone and therefore prevent the follicular development, any further follicular development in the ovaries. And you're going to also maintain a stable endometrium. Remember that an endometrium that is supported by estrogen is quite stable as opposed to an endometrium that is supported by progesterone. So remember, estrogen is also useful for better cycle controls, and it's going to prevent the breakthrough bleeding as what we see most commonly in the progesterone-only contraceptive pills. In terms of progesterone, it's going to be inhibiting the luteinizing hormone as well as the gonadotropin-releasing hormone. And remember that once you prevent this surge of the luteinizing hormone, this is going to be inhibiting the ovulation, and this is also going to be helpful in counteracting the adverse effects of estrogen on the endometrium. Remember that endometrial hyperplasia and heavy withdrawal actually causes an unstable endometrium in terms of progesterone. That's why the estrogen is present to balance this out. In terms of the peripheral mechanism of action of these combined oral contraceptive pills, remember that they're going to be making the endometrium atrophic. They'll make it a hostile environment for implantation to take place. They're also going to alter the cervical mucus to prevent the sperm from actually ascending into the uterine cavity. And remember that once you produce this static endometrial hypoplasia, there's going to be stromal edema, there's going to be a decidual reaction, there's going to be regression of the glands, and this is actually going to be making the endometrium not really receptive to the embryo. The progesterone actually is going to be making the cervical mucus thick and viscid as well as scanty. So this is going to prevent the sperm penetration. In addition to this, remember the contraceptive pills, especially those that have progesterone, are going to be affecting the motility of the fallopian tube and the uterus. Remember that progesterone is a smooth muscle relaxant. This means that you must keep in mind that if the progesterone-only contraceptive pills fail, there is a high risk of developing the ectopic pregnancies. In terms of formulations, remember that many different brands are going to be existing of the different hormones that have different dosages and pill taking schedules. In terms of estrogen, the most modern common synthetic estrogen is, like I said, it's ethinyl estradiol, which is going to be given in daily doses of about 10 to 35 micrograms, but we use a threshold of about 15 to 35 micrograms. And these are going to be containing lower doses, and they're going to be associated, the ones that are going to be containing lower doses rather are going to be associated with poorer controls of the cycle, while those that have higher doses can be given in special situations, which we will talk about. Remember that any drug that is given that is going to be stimulating the cytochrome P450 can actually potentially reduce the effective concentration of these contraceptives inside the bloodstream. Therefore, you want to give a higher dose, such as a 50 micrograms ethinyl estradiol. But if you increase the dose beyond this 50, there's going to be increased risk of both arterial and venous thrombosis. But now we have a newer preparation that contains this natural estrogen, such as estradiol valerate, in place of the synthetic ethinyl estradiol, though the benefits as well as the advantages are not yet well seen. In terms of progestogens, most of the combined oral contraceptive pills are going to be consisting of either the second class or the third generation progestogens. The second generation pills are going to be derivatives of norethindrone and even levonorgestrel. Then the third generation pills are going to include desogestrel, gestodine, as well as norgestamate. And the fourth generation progestins, such as drospirenone, are actually analogs of spironolactone, and they have an anti-androgenic as well as anti-mineralocorticoid action, and these are going to be used for treatment like hirsutism and acne, and these are going to have a side effect of potassium retention. Remember that the most commonly used progestins are with levonorgestrel as well as norethisterone as well as desogestrel. All the combined oral contraceptive pills have a similar efficacy. Remember the difference between effectiveness and efficacy. Efficacy is simply how this contraceptive method would work in an ideal setup. But remember, we live in a real world. We don't live in an ideal setup. So people tend to forget things. But in an ideal setup, the pregnancy rate after 1 year of use is about 0.3% with perfect use. But then it's about 9% with typical use, because this is how effective it is, because some people have inconsistent use of the combined oral contraceptive pills. Some common formulations that I want you to keep in mind that may be present in our setup here. You may have microgynon 30, which is going to be consisting of levonorgestrel, 150 micrograms, and ethinyl estradiol, 30 micrograms. So it's going to be containing 21 active tablets and 7 inactive tablets. The inactive tablets are going to be iron tablets. Then you have the microgynon 30 ED, which is going to be consisting of levonorgestrel, 150 micrograms, ethinyl estradiol, 30 micrograms, and these white inactive tablets. Then you have Diane 35, which consists of 2 milligrams cyproterone acetate as well as 0.035 milligrams of ethinyl estradiol. You also have Oraclon, which is going to be Oraclon 30 ED, consisting of levonorgestrel 150 micrograms and ethinyl estradiol 30 micrograms. Now, what are the regimens that we actually use in terms of taking these oral contraceptive pills? Remember that the doses of the estrogen and progestins are the same throughout the month. In some of the pills, we refer to these as monophasic. Then they may change throughout the month in other types of pills, which we refer to as multiphasic. You may have biphasic pills, which change only twice. You have triphasic, which change 3 times. You have quadriphasic, which change 4 times. And these are actually a bit more complicated to take, but have fewer real advantages compared to the monophasic pills, which is why we mostly just prescribe the monophasic pills. So with the triphasic pills, for example, the hormone doses actually that are present in all the pills, they have the minimum dose to provide the contraceptive effect in the early parts of the cycle. Then the slightly higher doses are going to be found in the later parts of the cycle, and these are meant to prevent any breakthrough bleeding. So how would this work? This is actually in an attempt to minimize the undesirable side effect on the lipid metabolism of these contraceptive pills. So this is due to the total low amount of the steroids and a balanced estrogen and progesterone relationship, such that if you had this Triquilla tablets, the first 6 tablets are going to be containing 0.05 milligrams of levonorgestrel and 30 micrograms of ethinyl estradiol. Then the next are going to be containing 0.075 of levonorgestrel and 40 of ethinyl estradiol. Then the last 10 are going to be consisting of 0.125 levonorgestrel as well as 30 of ethinyl estradiol. And these can be taken just like the conventional pill, where you take 1 pill each and every single day. So in terms of the pills, most models actually have a 21-7 model, where you have 21 active pills that are going to be consisting of estrogen plus a progestin that a person is going to be taking for 21 days. Then for 7 days, they take this inactive pill or the placebo pill. Then in other models, you may have a 24-4 model where they take the active pill for 24 days and they take the placebo for 4 days. These inactive pills are pretty much taken to allow for withdrawal bleeding. In the newer formulations, the placebo pill is actually going to be containing iron and folate, while in others, the pill actually is not really truly inactive because it's going to be containing these lower doses of ethinyl estradiol than those that they were taking in the previous weeks. Then remember that the combined oral contraceptive pills can also be taken in extended cycle formulations. For example, the 84-7, where you're taking 84 pills, then each pill is taken until you have 84, you're taking it for 84 days, then afterwards you take 7 placebos. Or is a continuous use where you're just taking the active pills each and every single day without actually having any placebo pills. So here is an example of what the 27-7 model actually looks like. As you can see, you're going to start from here. This is going to be 1, and you're going to be following them like that. Day 1, day 2, day 3, up until day 21. Then these ones here, which are red, are going to be inactive pills that are either going to be consisting of folic acid and the ferrous sulfate. So how do we initiate these oral contraceptive pills? So remember, before we actually start them, you must take a medical, social, and a family history, a thorough one, to check for any potential contraindications to their use. Remember that a history should be thorough and should be actually screening for certain contraindications, such as history of headaches, history of migraines, history of breast cancer, history of cervical cancer. A blood pressure history also must be taken, and you must also take a blood pressure measurement and also check the urine to ensure that this person is not pregnant. Remember that the oral contraceptives should not be prescribed unless the BP is normal and the results of the urine pregnancy test are negative. A physical examination is not really mandatory when they are starting the contraceptive pills, but a physical examination is often recommended within 1 year of oral contraceptive pill initiation. So a follow-up visit in the 3 months may be useful for discussing any potential adverse effects and for rechecking the blood pressure. Remember, you want to examine the breast for any nodules. You want to check the weight of the patient. You want to look at the blood pressure. You want to note the pelvic examination to actually rule out any cervical pathology, and pregnancy should be excluded. A cervical cytology must be done to exclude abnormal cells. Remember when we talked about the eligibility criteria, because I will mention this in the subsequent slides. So just keep this in mind. I talked about this in the previous video. I'm not going to go over it again. I just wanted to put this slide here to remind you about the eligibility criteria, because I would be just mentioning that these are the different categories and these are the things that you want to look out for in terms of contraceptive pills. So what are some of the indications? Those that are falling under category 1, those that can use these oral contraceptive pills. It may be age, from menarche to 40 years, post-abortion, those that have anemia, for example, iron deficiency or malaria, especially iron deficiency, those are where you want to stop the period if they have menorrhagia and you want to stop the period. Those with HIV and AIDS, additional to condom use, gestational trophoblastic neoplasia following normal HCG levels, those that have a history of ectopic pregnancy, those with endometriosis, those with uterine fibroids, those with ovarian or endometrial cancer, those with dysmenorrhea, those with dysfunctional uterine bleeding, those with PID, epilepsy, thyroid disease, varicose veins, tuberculosis, and benign breast disease. So how do we initiate these combined oral contraceptive pills? Remember, they can be prescribed at 13 months at a time, so they can take them for 1 year, 1 month. So the oral contraceptive pills may be started on the same day of the contraceptive visit. We refer to this as a quick start method. And the day of the week and the time in the menstrual cycle is not really so important in terms of the combined oral contraceptive pills. However, what you must mention to this patient is that if they are starting these pills after 5 days of the first day of their menses, then the woman should have this backup contraceptive methods for at least 7 days, because you want to wait for these contraceptive pills to actually reach their peak and for them to reach their maximum effectiveness. So you want to advise them to use some added contraception within the first 7 days. So if it's a new user, they should normally start their pill pack on day 1 of their cycle. This makes it much easier and it offers them protection throughout the entire cycle. So they take 1 tablet at bedtime, preferably for a consecutive 21 days. Then they have a 7-day break. And this routine is actually going to offer them protection from the time they take the first pill. Then the next pack should actually be started on the 8th day after you finish your break week. And irrespective of whether you're bleeding or not, and you should start the pill on the same day of the week the pill is finished. Then a simple regimen, like I said, 3 weeks on, 1 week off is the one that we're going to be following with this 21/7 model. In a pack that has 28 tablets, where there is actually no break, then it means that 7 of those pills are actually dummies and are going to be containing either iron or vitamin preparations. However, a woman can actually start the pill up to 5 days of bleeding, but they should use a condom in the next 7 days until the levels of these hormones are actually effective to offer the contraceptive protection for this woman. Remember that the pill should be started on the day after abortion. It can be started following childbirth in non-lactating women. Remember, you want to avoid this in lactating women because it will reduce the quality and the quantity of milk that is produced from the mother because of the both hormones that are present inside, especially the estrogen that is present inside the pills. It can be started after 3 weeks, and in lactating women, it should be withheld for 6 months. In terms of the progestin-only contraceptives, these ones are a bit strict in how you take them. So they must be taken every single day and at the same time. So if more than 27 hours has elapsed between doses of a progestin-only contraceptive, then this woman should use a backup contraceptive methods for 7 days. Some people even advocate for using up to 14 days. If you miss these tablets within a duration of 3 hours even, then you're at risk of actually falling pregnant. So it means you must use extra protection in the next 2 days. So most women are actually given a 3-month supply of contraceptive pills in the first instance, and then have these 6 to 12 monthly reviews thereafter. And women need clear advice on what to do if they miss any pills, of which I spend so much time, and I'm going to labor on talking about the missed pills because that's something that people don't really understand. So the patient should be examined after 3 months, then after 6 months, and then we can do it yearly. And the patients above 35 years, you can check them much more frequently. And at each and every single visit, you must actually note any adverse symptoms, examine the breast, the weight, the blood pressure, and as well as perform a pelvic examination, including any cervical cytology. And you must compare this with previous records that are present. Remember also that the contraceptive pills can be used in women who prefer to bleed at an interval of 60 to 80 days, about 3 to 4 times a year. So that's when we can use extended use of the pills in these women, and they should take only the active pills from the pack. And immediately they finish the active pills, for example, they reach day 21, they discard that pack and they get a new pack and start taking the active pills. So remember that the pills should be continued for 60 to 80 days. Then the withdrawal bleeding can be allowed, where they take about 84 pills that are active, then this is followed by 7 placebo pills. And remember, this is going to result in seasonal withdrawal bleeding at an interval of about 4 months. Any monophasic pill may actually be used in this manner. So remember that the pill regimen with 24 active pills, like I said, is going to follow 4 placebo pills, and this is going to result in menses at 28 days intervals with lesser bleeding, both in amount as well as days, and failure rate is also less. So a woman that does not smoke and has no other risk factors of cardiovascular disease may actually continue the pill with close monitoring until the age of 55 years. Now, what about missed pills? Because people come in to your office and they'll ask you, Doc, I've missed 2 pills. What should I do? Or they'll send you a message, I've missed 2 pills. What should I do? I've missed my contraceptive pills. What should I do? So normally there is return of the pituitary and ovarian follicular activity during the pill-free interval period, which is those 7 days when you're taking those inactive pills. So it means that breakthrough ovulation can actually even happen in 20% of the cases. It doesn't mean that if you're taking those 7 inactive pills, you have protection. You can still fall pregnant even during that week. So, lengthening of the pill-free interval due to omissions or malabsorption or vomiting either at the start or the end of the pack does increase the risk of breakthrough ovulation, and it does increase the risk of pregnancy. Keep that in mind. So for the combined oral contraceptive pills, like I say, timing is not as strict as is with the progesterone only. So if the combined oral contraceptive pill user actually misses 1 pill up until 24 hours, then she can take when she remembers that she has forgotten, she take the 2 pills the next day, the missed pill as well as the pill for that particular day, and then continue with the rest of the schedule as is. If they have forgotten to take the pill for 2 days, then they must resume taking the oral contraceptive pills each and every single day, but they must be using a backup contraceptive method for 7 days. If they forgot to take the pill for 2 days and have had unprotected sexual intercourse in the 5 days before forgetting to take the pill, then they must take some emergency contraception. When she misses 2 pills in the first week, that's from day 1 to day 7, she should take 2 pills on the next 2 days and then continue the rest of the schedule. So the extra precaution must be taken also in the 7 days, either by using condom or abstinence. Remember, the key word here is the 7 days, what we term the 7-day rule. And then if she misses 2 pills in the 3rd week, that's between day 15 and 21, or more than 2 active pills are missed at any time, then another form of contraception must be used as a backup the next 7 days, because it takes about a week for these things to be quite effective, as you have seen. So if she misses any of the 7 inactive pills in a 28 pack only, she should actually throw them away, and she should take the remaining pills one at a day or one at a time, and then start the new pack as she would normally would. So here is a schematic that helps us. Let's have a look at it. So if 1 or 2 30 to 35 micrograms ethinyl estradiol pills have been missed at any time, or 1 20 microgram ethinyl estradiol pill is missed, so she should take the most recent missed pill as soon as she remembers. Then she should continue taking the remaining pills at her usual time. She does not require any additional contraceptive protection. She does not require any emergency contraception. She's still protected. If 3 or more of the 30 to 35 micrograms of ethinyl estradiol pills have been missed at any time, or you missed 2 or more of the 20 micrograms ethinyl estradiol pills, then she must take the most recently missed pill as soon as she remembers. Then she should continue taking the remaining pills daily at the usual time. She should be advised to use extra protection or abstain from sexual intercourse for at least 7 days. Then in addition, because the extending pill interval is risky, then if the pills are missed in 1 week, then of course emergency contraception should be used if she's had any intercourse in that week. If the pills are missed in week 3, then of course you should finish the pills in a current pack and then start the new pack the next day, thus omitting that pill-free interval period. Now remember that the timing for starting the combined oral contraceptive pills generally tends to vary in pregnancy. So if it's after a first trimester abortion or a spontaneous or an induced miscarriage, it may be started immediately. If it's actually delivery at 12 to 28 weeks, you start them within 1 week if the woman has no significant risk of thromboembolism. If it's after delivery after 28 weeks, then these must not be started until after 3 weeks postpartum. Because remember, pregnancy itself is a hypercoagulable state. So if you give estrogen, there's a higher risk of thromboembolism. So you have to wait for at least 3 weeks if there is no additional risk of thromboembolism. And during the postpartum period, however, it should be delayed until the puerperium has ended, until 6 weeks. So if women are exclusively breastfeeding on demand, including night feeding and not supplementing with other feeds, then we shouldn't give these combined oral contraceptive pills, at least even for 6 months, because they reduce the quality and the quantity of the milk. And if there's a risk of venous thromboembolism that is increased because of a recent cesarean section delivery, then do not give these combined oral contraceptive pills. So 98% of the women who are exclusively breastfeeding, and in those that have menses that do not resume during pregnancy and within the 6 months period after delivery, no contraception is actually needed because they have this lactational amenorrhea which protects them from getting pregnant. And these women are often advised to start contraception usually within 3 months of after delivery rather. Then the progestin-only oral contraceptive pills can be used immediately postpartum because they don't significantly increase the risk of postpartum venous thromboembolism, and they don't affect milk production. Then if a woman has had a history of liver disorder, we must get a test to check for any normal liver function, and this should be done before the oral contraceptives are prescribed. Remember that women at risk of diabetes, those that have a family history, those with gestational diabetes, those that have given birth to large for dates infants or high birth weight infants, those that are above 4 kg, or those that have physical signs of insulin resistance such as acanthosis nigricans, this black velvety-like appearance of the skin that is very common in the armpits, the nape of the neck, and those that require plasma glucose. These are going to be requiring plasma glucose screening and a complete serum lipid profile annually. Remember that use of low-dose oral contraceptive pills is not contraindicated by abnormal glucose or lipid test results, except if the triglycerides are greater than 2.8 millimoles per liter. That's about 250 milligrams per deciliter. Most of the women with diabetes may actually take a combination oral contraceptive pills, with exception to those that have vascular complications such as neuropathies, retinopathies, or nephropathies, and those that have had diabetes for more than 20 years. What about certain drug interactions in terms of combined oral contraceptive pills? Remember that they can actually slow the metabolism of certain drugs such as meperidine, but this is not really clinically important. What is clinically important is to remember is that some drugs that are going to be inducing the enzymes, the cytochrome P450 isoenzymes, these are going to accelerate the transformation of the oral contraceptive pills to less biologically active metabolites. So they decrease the efficacy of these combined oral contraceptive pills. So women that are taking these drugs should not be given contraceptive pills concurrently unless if other contraceptive methods are unavailable. That's when we can now use that 50 micromoles of ethanoestradiol pill. We can actually combine it if we're using, or if this person is on any of these following drugs. So these drugs include anti-seizure medications like phenytoin, carbamazepine, barbiturates, primidone, topiramate, and oxcarbazepine. You may also have ritonavir-boosted protease inhibitors, those that are HIV-positive individuals, rifampin, as well as rifampicin, those that are being treated for TB. So here we use higher preparations, 50 micrograms, most commonly are going to be used to counteract this increased liver metabolism. Lamotrigine should not be used with oral contraceptives because remember, oral contraceptives decrease lamotrigine levels and can actually even affect a seizure control. Some broad-spectrum antibiotics like amoxicillin, tetracycline, and doxycycline can alter the intestinal absorption of contraceptive pills and therefore reduce the efficacy. So additional contraceptive measures must be used during antibiotic therapy for 1 week and continue 1 week after the antibiotic therapy has ended. What are some of the indications of stopping contraceptive pills? If a patient comes in with severe migraines, visual or speech disturbances, sudden chest pain, unexplained fainting attacks or acute vertigo, severe cramps and pains in the legs, excessive weight gain, severe depression. If they're prior to surgery, we must stop them at least 6 weeks prior to any to minimize any post-operative vascular complications. And for patients wanting to become pregnant, remember ovulation tends to return within 3 months of withdrawal of the drugs in about 90% of the cases. What are some of the contraindications? Remember the medical eligibility criteria for the contraceptive use. They're going to be related to those that are category 3, meaning that the disadvantages outweigh the advantages, and those that are category 4, meaning that we don't give these contraceptive pills regardless of the situation. So most of these are going to be related to the side effects of the sex steroid hormones on the cardiovascular as well as hepatic systems. So remember that women should ideally discontinue the combined oral contraceptive pills at least 2 months before any elective pelvic or leg surgery because of the risk of venous thromboembolism. And these contraindications are also valid as we'll talk about the patches and the vaginal rings in the subsequent lectures. Remember, the risk of adverse effects of estrogen, progestin, contraceptives varies depending on the risk factors as well as associated complications. Again, I will show you the slide on the medical eligibility criteria, and this is just to help you and give you some perspective of the different classes. So we'll begin with class 4, those that can't take these contraceptive pills. These are the conditions. Those that are less than 21 days postpartum, that's 3 weeks. Those with thrombogenic mutations, thrombophilias, including antiphospholipid syndrome or current or past venous thromboembolism. Those that have had DVTs or pulmonary embolisms. Those with active cancer, whether metastatic, they are receiving therapy, or within 6 months after clinical remission, excluding non-melanoma skin cancer. Those with current breast cancer, prolonged immobility due to major surgeries, migraines with auras, migraines without auras in the age above or equal to 35, those that are smoking in women that are above or at the age of 35, and those that are smoking more than 15 cigarettes per day. Those with severe hypertension, a systolic BP greater than 160, diastolic greater than 100, or complicated vascular disease. Those with peripartum cardiomyopathy less than 6 months, or with moderately or severely impaired cardiac function. Those with ischemic heart disease, or multiple factors for atherosclerotic cardiovascular disease. Those with stroke, which could be current or history of stroke. Those with valvular heart disease with complications, that's hypertension with vascular disease. Those with diabetes for more than 20 years or with vascular disease like neuropathies, nephropathies, retinopathies. Those with systemic lupus erythematosus with a positive or unknown status or unknown antiphospholipid antibodies that are present. Those with solid organ transplant with complications. Those with severe or decompensated cirrhosis. Those with hepatocellular adenomas. Those with liver cancers. Those with active viral hepatitis. Those that are breastfeeding less than 6 weeks postpartum. Do not give combined oral contraceptive pills to these patients. And those that are category 3, those that are less than 6 weeks postpartum with risk factors for venous thromboembolism. Remember here, these are the disadvantages greatly outweighing the advantages. Those with multiple risk factors for arterial disease, those with hypertension and systolic blood pressure 140 to 159, this is supposed to be 140, not 14, and diastolic 90 to 99, or those that have adequately treated hypertension less than 140 over 90, some known hyperlipidemias, diabetes with vascular disease, superficial venous thrombosis, that's thrombosis associated with peripheral intravenous catheter, may be a lower risk. Breast cancer and no evidence of current disease for 5 years, smoking less than 35 years, less than 15 cigarettes per day, obesity, migraine even without aura in an age greater than 35, peripartum cardiomyopathies more than 6 months, breastfeeding until 6 months postpartum, multiple sclerosis with prolonged immobility, inflammatory bowel disease if risk factors for venous thromboembolism are present, current or medical treatment of gallbladder disease, or history of contraceptive-related cholestasis, a history of cholestasis related to combined oral contraceptive pills, bariatric surgery with malabsorption due to shortening function, small intestinal length, such as gastric bypasses or biliopancreatic diversions, those with current treatment with any of these following drugs, especially with the anti-seizure medications. Again, here's a picture that summarizes everything in the different categories. These are relative contraindications of contraceptive use, and these are absolute contraindications for contraceptive use. You can take your time, pause this video, have a look at these conditions, make sure that you know them because they do ask them on your exams. And again, same thing here, the indications of the oral contraceptive pills, those are falling under category 1. These are the relative contraindications, category 2 and 3, and these are the absolute contraindications, category 4. What are some of the advantages and disadvantages of the combined oral contraceptive pills? They are highly effective. There's good cycle control. They are well tolerated in most of people. They have additional non-contraceptive benefits that we'll talk about. And the low-dose pills with lipid-friendly progestins further reduces the risk. There's a reversibility rate which is prompt within 3 months. Disadvantages is that it requires education and motivation because you're taking it every single day for the whole month. There is a limitation in its use. It requires initial checkup and periodic supervision. There is inconvenience that's caused in its use due to daily schedules. You can't skip a day, and there's a risk of drug interactions. It's costly, but free supply through the government channels. Now, what about the progestin-only contraceptives? Remember that these ones do not have any estrogen in them. They only are going to be consisting of progestogens, and this avoids the risk and side effects that are related to estrogen. Most of the pills are going to be consisting of second-generation progestogen, norethisterone or nogestrel, or their derivatives, and the third-generation desogestrel. So it's going to be containing very low doses of a progestin in one of the following things. It could be levonorgestrel, 75 micrograms, norethisterone, 350 micrograms, desogestrel, 75 micrograms, lenasterone, 500 micrograms, nogestrel, 30 micrograms. And remember, these have to be taken daily from the first day of the cycle and at the same time. What's the mechanism of action? Remember that the progestin-only oral contraceptives are quite effective contraception because they're going to be thickening the cervical mucus and they're going to be preventing the passage of the sperm through the cervical canal and in the endometrial cavity to fertilize the egg. They also are going to be making the endometrium thin and atrophic, thereby preventing implantation and reducing the tubal mobility. So this is going to be increasing the risk of ectopic pregnancy if they fail. At higher doses, the progestogen-only methods actually can also centrally inhibit the ovulation in about 2% of the cases, and 50% of women actually tend to ovulate normally, and making them a highly effective thing, but this is not really a primary mechanism of action. But we'll talk about more of this when we talk about the emergency contraception. Now, how do we prescribe the pill? Remember that these must be taken on the first day of the cycle and then continuously, so there are no breaks between the packs, and it has to be taken regularly at the same time of the day and for them to be effective. If a pill is delayed for more than 3 hours, then additional precautions or abstinence is needed until the pill can be taken continuously for 14 days, especially in the very first 2 days. Remember also that the same dose is taken daily. There are no inactive pills that are included. Like I already said, the breakthrough bleeding is a common adverse effect, and they are often prescribed when women wish to take these contraceptive pills, but estrogen is contraindicated. For example, a woman that has cardiovascular risk factors and someone who's older and smokes. And remember, this progestogen-only pills are ideal for women who like the convenience of pill taking but wish to avoid the combined oral contraceptive pills. The pregnancy rate with perfect and typical use with progestin only are quite similar to those with the combined oral contraceptive pills. And remember that if these fail, like I said, there's a slightly higher risk of ectopic pregnancy. The progesterone-only contraceptive pills that contain higher doses of desogestrel can actually inhibit ovulation in almost every cycle, and these are the pill of choice for younger women and for those that cannot take combined pills. What are some of the indications and common side effects? These are going to include breast feeding. Those that are breastfeeding, you can give these pills. Older age, you can give these pills. Those with cardiovascular risk factors such as high blood pressure, smoking, diabetes, you can give them these pills. And common side effects include erratic and absent menstrual bleeding, simple functional ovarian cysts, though these do not need any surgery. Then you may also have breast tenderness and acne. So category 3, where the the disadvantages outweigh the advantages. These are also the same for implants, injectables that have progesterone in them. So women with current breast cancer should not take the progestin-only pills. Those with implants or injections should not take them. So these include conditions like past breast cancer with no evidence of current disease for 5 years, unexplained vaginal bleeding, current and history of ischemic heart disease, severe or decompensated cirrhosis, hepatocellular adenomas, or liver cancer, history of jejunal bypass for the progestin-only pills, current treatment with rifampicin, rifampicin, or certain anti-seizure medication for progestin-only pills, ischemic heart disease, severe hypertension, or multiple risk factors for atherosclerotic cardiovascular disease for progestin contraceptive injection, vascular disease, including due to diabetes or systemic lupus erythematosus for progestin contraceptive injections. Here are some of the advantages and disadvantages of progestin-only pills. So advantages are going to be things like there are no side effects related to estrogen. There are no adverse effects on lactation and can be suitably prescribed to lactating women, so they are often referred to as the lactation pills. They're easy to take and there is no on and off regimen. It may be prescribed in patients having medical disorders such as hypertension, fibroids, diabetes, epilepsy, smoking, and a history of thromboembolism. They do reduce the risk of PID and endometrial cancer, but disadvantages include that things like acne, mastalgia, breakthrough bleeding, or at times amenorrhea in about 20 to 30% of the cases, and all the side effects attributed to progestins may be evident. Simple cysts of the ovary may be seen, but they do not require any surgery, like I already said. Failure rate is about 0.5 to 2% per 100 women years. And the failure is often in young compared to women over 40. Women using the drug that induce the liver microenzymes to alter the metabolism should avoid this method of contraception. In terms of the benefits of the oral contraceptives, remember that the high and low dose combination oral contraceptive decrease the risk of things like endometrial cancer by 60% after at least 10 years of use, and ovarian cancer by about 50% after 5 years of use and 80% after about 10 years of use, colorectal cancer. Remember that there is a decreased risk of functional ovarian cyst, benign ovarian tumors, abnormal uterine bleeding due to ovulatory dysfunction, dysmenorrhea, premenstrual dysmorphic syndrome, iron deficiency anemia, and benign breast disorders. Salpingitis, which can impair fertility, occurs less frequently in oral contraceptive users. Remember that the combined oral contraceptive pills users generally have light, pain-free, regular bleeding, and therefore these are going to be used to treat heavy menses, painful period, and they can also improve the premenstrual syndrome and reduce the risk of pelvic inflammatory disease. They can also be used for the treatment of acne. Now, what are some of the adverse effects? And this is the most important thing, because most women will come in and say, I've had side effects of these contraceptive pills. What do you advise? So remember that the overall risk of adverse effects is small. Common adverse effects include things like CNS, things like depressed mood swings, headaches, loss of libido, breast tenderness, breast enlargement. You may have gastrointestinal symptoms like nausea, bloating, perceived weight gain. You may have reproductive system symptoms such as breakthrough bleeding and increased vaginal discharge. You may have other miscellaneous complications such as cloasma. I show you a picture on the last slide of these lectures, which may worsen with time on the combined oral contraceptive pills, fluid retention, and even change in contact lenses. Remember that although some of these side effects are minor, they frequently lead to early discontinuation, and many minor side effects will settle within a few weeks of starting the contraceptive pills. Other side effects to be wary of include amenorrhea or breakthrough bleeding, especially while taking the active pills with prolonged duration of use of the combined oral contraceptive pills. Either adverse effect can be managed by either changing to a pill with higher doses of estrogen, and remember that the progestin-only pills often are going to be causing irregular vaginal bleeding. You may also have a long return to fertility. Most should come back. Ovulation should actually come back after stoppage within 3 months in 90% of the patient, but sometimes it may remain inhibited for a few months after stopping the oral contraceptive, but it's not a long-term effect on fertility. Remember that they do not adversely affect the outcome of pregnancy when the contraception occurs during or after their use. Weight gain can be accompanied by bloating and edema. And remember, estrogen increases aldosterone production and causes sodium retention, which can cause dose-related reversible increases in the blood pressure and in the weight, up to about 2 kg. Remember that there is also a reduction in the amount and the quality of milk in the purparium, especially with use with combined oral contraceptive pills. There is an anti-androgenic effect where there may be acne, nervousness, and an anabolic effect resulting in weight gain. Most progestins used in the oral contraceptives are related to 19-no-testosterone and are androgenic. So nogestamate, etonogestrel, and even desogestrel are less androgenic than levonorgestrel, norethindrone, as well as norethindrone, then acetate, as well as ethanol diacetate. So if a woman gains more than 4.5 kg per year, a less androgenic oral contraceptive pill should be used. And the newer fourth generation anti-androgenic progestins include Dionogest and even drosperinone. These are related to spironolactone, which is a diuretic. There is an adverse effect of DVT and thromboembolism. Remember that use of these combined oral contraceptive pills increases the risk by about 3 to 5 times, and the estrogen can actually alter the blood clotting mechanism and the coagulation proteins, and it can actually induce a prothrombotic tendency, though the mechanism is poorly understood. This increases as the dose of estrogen also increases, and remember with combined oral contraceptive pills with about 10 to 35 micrograms of estrogen have about 2 to 4 times the risk at baseline, and the risk is slightly much lower than the risk associated with pregnancy. The progestins in the combined oral contraceptive pills can also affect the risk. Remember that those that contain levonorgestrel appear to have a lower risk than those that contain the third generation progestogens that have twice the risk, like drosperinone as well as desogestrel. So the risk is probably because the steroid hormones actually are going to increase the production of the clotting factors in the liver and increase platelet adhesion. If the DVT and pulmonary embolism is suspected, we should stop the contraceptive immediately and perform diagnostic tests to confirm or exclude the disease. And remember, these oral contraceptive pills must be stopped 1 month before any major surgeries, as these may require immobilization for a long time and should not be taken again until 1 month after the surgery. Women with a history of high venous thromboembolism should not use oral contraceptive pills that have estrogen. And generally, women with a significant family history of venous thromboembolism should carefully be assessed and tested for inherent thrombophilias prior to them being prescribed contraceptive pills. Remember that the risk of venous thromboembolism is about 5 in 100,000 for the normal population, 15 in 100,000 for users of second-generation contraceptives, third in per 100,000 users for those with third-generation contraceptions, and 60 per 100,000 in the pregnant women. You may also have arterial disease, which is less common than venous thromboembolism, but it's actually much more serious. There is a risk of myocardial infarction and thrombotic stroke in young and healthy women using low-dose contraceptive, but it's very rare. It's extremely small. And those that have cigarette smoking and high blood pressure with both increase the risk of any women who smokes must be advised to stop the contraceptive pill at the age of 35. And around about 1% of those that are taking the pills will become significantly hypertensive, and they should stop it when they notice this. Breast cancer also, though this has a bit of some controversy. There's a small increased risk in current or recent users, according to some studies, but remember that most of the people that are using these contraceptive pills are young, and they're already not at risk of developing breast cancer until maybe years later on when they have already stopped the use of the contraceptive pills. So advising women about the association of breast cancer and the combined oral contraceptive pills is actually very difficult. So women in their 40s or with strong family history of increased risk, most of the data also shows that any effect of the contraceptive pill use on breast cancer risk actually disappears after 10 years of stopping the contraceptive pills. You may also have cervical cancer. There's a slightly increased risk in women that have used the oral contraceptive pills for more than 5 years, but the risk decreases to baseline 10 years after stopping the oral contraceptive pills. And whether this risk is related to the hormone effect or to the behaviors of not using the barrier contraception is not really so clear. Then you have some central nervous system effects that there's increased risk of stroke, Remember that the low-dose contraceptive pills do not appear to increase the risk of stroke in healthy, normotensive, and non-smoking women. If there is any, however, focal neurologic symptoms such as aphasia or any symptoms that may herald stroke, then the oral contraceptive pills must be stopped immediately. Remember, smokers over 35 should not use oral contraceptive pills that contain estrogen because of the increased risk of myocardial infarction and the increased risk of stroke. There is also a dose-related insulin resistance with the use of the oral contraceptives with low progestin dose, and these are going to rarely resulting in hyperglycemia, but the progestins may cause reversible dose-related insulin resistance. In terms of the serum HDLs, the levels decrease with oral contraceptive pills with a high progesterone dose and are used when high progesterone doses are used, and usually they increase when the oral contraceptive pills with low progestins and estrogen doses are used. Remember that estrogen in oral contraceptive pills increases triglyceride levels and can actually exacerbate the pre-existing hypertriglyceridemia, and most alterations in the serum levels or other metabolites are not really clinically significant. Thyroxine binding globulin capacity may increase. However, the free levels of thyroxine and even the thyroid stimulating hormone and the thyroid function is not really affected. So you don't expect any form of the hyper or hypothyroidism. There is a decrease in the levels of pyridoxine, folic, B-complex vitamins, ascorbic acid, calcium, manganese, zinc, and increased levels of vitamin A levels, though these are not really clinically significant and they don't really need any supplementation. You may also have cholestasis or jaundice. Remember, women that have had cholestasis of pregnancy, whether idiopathic recurrent jaundice or pregnancy, may become jaundice if they are taking oral contraceptives, and the oral contraceptives must be used with caution. There is a risk of gallstones, and it's not increased by use of low-dose oral contraceptive pills. There may be rupture of benign hepatic adenomas, and remember the incidence increases as the duration of use and oral contraceptive dose increases, and adenomas usually regress spontaneously after you stop the oral contraceptive pills. Melasma in some women can actually be accentuated by sunlight, and it will disappear slowly after you have stopped the oral contraceptive pills because the treatment is difficult. And the oral contraceptive pills must be stopped when melasma actually first appears. Remember that oral contraceptive pills do not increase the risk of melanoma. And this is what melasma actually looks like. I'm sure I've seen some people that have had this type of skin lesion in the general public. I really hope you enjoyed this lecture on oral contraceptive pills. If you did, consider subscribing to the channel. I know it was a very long lecture. Apologies for that, but it was necessary. I hope you understand everything. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.